Good afternoon, everybody. Thank you for joining us again this week. I see we've opened up the lobby and people are rapidly joining us. Um, so we're going to give everybody a few minutes, but we'll try to get started as close as possible to the noon time frame. This week we have a significant amount of material to go over, so we want to try to stay on target there. As a reminder, these sessions are being recorded. And so that we ask in the beginning of the session, and these will be posted on the Florida HFMA YouTube channel. We do ask that you put your do not share video and stay on mute until we open up the questions at the end of the session. We will have a chat session that is being manned by Anthony for us. And so if he can answer any of the questions, whether it's technical, he'll be able to do this. So if not, we'll review those questions at end. And then certainly start taking some live Q&A as well as possible. So again, we do ask that you try to stay off video and stay off of chat and off of audio until we start sharing live at the end of the session. So today we're going to be going over, this is our fourth session out of 9. We have 4 units to go through. So we've got 4 units to go through today. Health plans, more detail about managed care. We'll talk about price transparency, and we'll also talk about the importance of patient financial communications. As a reminder, please ensure that you sign on to your e-learning within HFMA, sign up and register for the CRCR, and then take these modules again before next week's call. I will actually open it up to see, are there any questions from anybody from last week's session? And Anthony, if there are any in the chat, if you could just share any questions from last week that anybody wanted to review based on types of patients. We talked about scheduling and the importance of pre-registration. Okay. All right. So I'm going to leave that there and we'll go on. And any questions from last week, we can also go over at the end of the session. Okay. So today we're going to identify the basic billing rules for the major health plans. We're going to do an overview of basic billing features and benefits, basic rule types, and then we're going to talk about some of the minor claim payers and the plans that you'll see out there in the industry. So many people under the age of 65 receive health care through an employer. Others buy their insurance through the individual market or the insurance marketplace, also known as the insurance exchange created by the Affordable Care Act. In addition, there are clearly federal and state health insurance programs available to qualifying individuals. We are going to do a much deeper dive into Medicare and Medicaid. So we're over the next few slides. So let's talk about the other health plans. TRICARE, formerly known as CHAMPUS, is the Uniformed Services Healthcare Program for active duty service members and their family, retired service members and their family, members of the National Guard and Reserve, their family survivors, and other who are eligible. TRICARE plans include TRICARE Prime, TRICARE Standard and Extra, and what they call TRICARE for Life. Indian Health Services, which you would probably only see if you're near a standard Indian reservation, but could see in other places, is an agency within the Department of Health and Human Services and is responsible for providing health services to Native Americans. The blue brands, as we call them, your Blue Crosses and your Blue Shields, I'm sure everybody's heard of those. Many of them are covered by them. Are the nation's oldest and largest family of benefit companies, and it's the most recognized brands in the healthcare industry, starting over 75 years ago. What is unique about Blue Cross and Blue Shield is they share one adjudication system across the country, which makes it easier usually for providers. Managed care plans are those that may cost less for an individual, but has significant administrative requirements both on a patient side and on a provider side. So really understanding managed care plans and what their prior requirements are, like authorization and referrals, is key to making sure that patients and providers get paid for what they do. Commercial indemnity plans, those tend to be maybe a little bit more costly for patients and employers, but have less restrictions and allow patients to possibly self-serve to a specialist, doesn't require referrals, doesn't require authorization. So, but again, usually a little bit more costly. Liability coverage is when clearly there's a liability either due to an auto accident or a site or premise site accident. Reminder, we've talked about this now. This will be the third time. Liability is not covered or is not in play if the accident is at the individual's own home. That goes under the regular insurance. Liability will always have to be exhausted before any other payers can be built, and they will require proof of that exhaustion. Insured plans are when an employer chooses to actually pay for the services that their employees actually receive, not insurance per se, but they're actually going to pay for that. They usually contract with a third-party administrator to do the administrative processes of processing the claims, processing the remits, but the actual cost of care comes out to them. Now, certainly there are some stop-loss gas plans and things they'll do to make sure that their employees' healthcare costs don't bankrupt them. So definitely a unique perspective on insurance carriers. So we'll focus on Medicare. Hopefully most of you are familiar with that. We'll talk about the types, the benefits under each one, about the unique Medicare claim submission and Medicare claim status. It's government sponsored and it's financed through taxes and general revenue and the General Revenue Fund. The Medicare types are Medicare Part A, that provides benefit coverage for inpatient hospital services, skilled nursing care, and home health. Part B benefits are available for outpatient and professional services coverage, but the beneficiary must pay a monthly premium for the additional coverage, so it doesn't always come into play, and there will be more copays and deductibles out of pocket. Medicare Part C is also known as Medicare Advantage. It typically includes both Part A and Part B. It may include the Part D coverage, but they are typically considered managed care plans and again may have more restrictions and administrative requirements for care than a standard fee-for-service Medicare Part A or Part B. And then Medicare Part D is also known as the Prescription Drug Coverage Program. So there are really four components to the Medicare coverages that you'll need to be aware of. Medicare Part A benefits. This is where the benefits get very complex to understand what benefit periods are and what Medicare really covers. So Medicare Part A consists of what we call benefit periods. The beneficiary remains in the same benefit period until he or she is hospitalization free and are skilled nursing care free for 60 days. A deductible is due each time a beneficiary is readmitted for a new benefit period. So if I'm in the hospital in January and I pay my current deductible is $14.08 per benefit period or hospitalization. If I now am in January and I don't come back into June, hopefully, or maybe never, I am now hospital free for 60 days. I start a new benefit period and I have to pay the deductible again of 1408. So it's not once a year, it's each time you're hospitalized, but you start a new benefit period. Medicare will pay full benefits other than the deductible for up to 60 days in a benefit period. And the full days renew with each new benefit period. If a patient is in a hospital, they've used their their six full days are used. The patient then moves into what we call co-insurance days. They have 30 of those, and they have a daily out-of-pocket expense, which is equal to 25% of the current deductible amount. So every day, 25% of that current 1408 is now patient liability. So now I've meet my 30, I've used my 60, I've used my 30. The beneficiary may opt, and that's a very important term you have to remember, to use their 60 lifetime reserve days. Again, opt, they have to be asked to use them. You can't just bill them. Daily out of pocket for each lifetime reserve day is 50% of the current deductible amount. So once I've used my lifetime days, I have no more lifetime reserve days. They never renew. So in an instance where a patient is unfortunately hospitalized, only has Medicare Part A coverage or Part B coverage, and is in the hospital for 190 days, it appears, they have no more Medicare Part A benefits. And I shared with you a link there that you can review, do a little bit additional readings about the Medicare Part B premiums, deductibles, and the benefit periods. But this is something that really patient access staff and revenue cycle folks need to focus on where that patient is in the benefit period, particularly if they don't have a secondary insurance that'll cover this. This could be significant cost to the patient if they start exhausting all of their Medicare Part A benefits. So how long must first polling question, guys, how long must a patient be hospital free to start a new benefit period? Okay. All right, we got a lot of answers out there, so we'll stop the polling question. 60, you're absolutely right. And one of the reasons we did hear from you loud and clear that you'd like more polling questions, so trying to intersperse that more in here. And I'm also trying to make sure that we reinforce what I believe, again, my opinion, haven't taken the test yet, what I think are maybe key concepts that you should understand. So we're going to want to do that. So moving on, we can stop sharing the poll results. Is that me? Okay, nope. I want to stop share. Okay, there you go. So let's talk about Medicare Part B coverage. Medicare Part B covers physician services, outpatient hospital services, certain home health services, durable medical equipment, and health services not covered by Medicare Part A. Again, patients have to pay beneficiary premiums on a yearly basis that is scalable based on income, and that will be on that link that I just gave you if you're interested on how that is calculated. Medicare Part B does have an annual deductible. The beneficiary is responsible for a coinsurance payment for all covered Part B services. I believe it's still 20%, excluding diagnostic lab services. So the coinsurance amounts for services that are paid under the outpatient prospective payment system each year is updated by CMS. And so each year, the Medicare premiums, deductibles, and co-payment rates are adjusted according to the Social Security Act. Okay. Come on. For some reason, my slide's not moving. There we go. Which Medicare plan covers home health services? So second polling question. Is it Part A, Part B, Part C, or Part D? I'll give you another few seconds. We've got about half answered. You don't have to answer, obviously. This is intended to try to hopefully be interactive. But all right, we've got a good portion. So we'll close the poll and share the results. The actual answer is Part A. And I know that, and that's why I pointed it out, because intuitively, home health services you think of as outpatient, right? They are doing in the patient's home. And then Part B says, oh, I cover outpatient services except home health services. So again, Part A is going to cover inpatient services, skilled nursing facilities, and home health services. Okay. Awesome. All right, so we'll get rid of that and we'll move on. Okay, let's talk about Medicare claim submission and statusing. So hospital inpatient and outpatient services are submitted to Medicare and Medicare Advantage plans using the 837I, are usually referred to as the UBO4. And physician services are submitted electronically using the 837P, are referred to sometimes as the CMS 1500. Just last year, finally, CMS replaced the Social Security-based HICN number with the MBI, Medicare Beneficiary Identifier, for all beneficiaries per the Medicare Access and CHIP Reauthorization Act of 2015. So any claim submitted with the old HICN number will reject. Patients should be presenting with their new cards, or you can look up MBIs for your Medicare patients when they don't or can't give them to you. You must have their first name, last name, date of birth, and Social Security number, and you can access it via your Mac Secure MBI lookup tool. Keep in mind, however, that the Social Security number may differ from the HICN number, which uses the Social Security number of the primary wage earner. So trying to do that lookup, you'll want the Social Security number of the patient. To be eligible for Medicare reimbursement, claims must be filed within 1 calendar year after the date of service. And for any of you who were doing Medicare billing, 10 years ago, this makes it, certainly we have less time to submit claims, but it's an easier knowledge, because there was this whole swing of the October before, 2 years before, and it got very complex as to figure out the timely filing of Medicare. So 1 year from date of service is when your claim needs to get submitted. They will reject or deny claims that are not received within the specified time requirements. When the Medicare administrator contractor receives the claim is either paid or denied, and an explanation of benefits or EOB is sent to the patient. In addition, they should get the ERA via the 835 remittance transaction. Let me see, I'm gonna go back one more. I just want to focus on, I didn't know if I put a slide in for that. Where Medicare is unique is that it also has what we call the fiscal intermediary system, or FIS, that allows providers to go out, and Medicare will reject or return to the provider claims that cannot be paid under its current submission. They actually allow providers to go out and work those RTP claims, either submit a new claim and see what the issue is, or correct it within FIS, which is a nice tool that we don't have the benefit of having for all providers and all payers. So it can speed up reimbursement, and it can eliminate the actual denial, the N-835 transaction, which is going to impact your cash collections, right, and your cash flow and your rework. So you'll hear many providers talk about being out in FIS to correct their RTP claims, and managing that Medicare RTP is a significant, has to be a significant follow-up activity for Medicare providers. Okay, so moving on, what is the timely filing for Medicare? I'm keeping our Damar's team very busy today with polling questions, so thank you for your support. All right, we've got almost half done, so yeah. Okay, we'll get it answered. We've got most people have answered it by now. It is 1 year. Tried to reinforce that as well, but you've got 1 year from the date of service to submit that claim. Used to be a kind of a rolling weird 2 years, but is a very clear guideline now of if that claim is 1 year and 1 day old, you cannot bill it to Medicare, you will get rejected. All right. Cool. All right. So let's talk about Medicaid. So to be eligible, an individual must meet income requirements and asset requirements and fall into one of the following major categories. So again, they're going to have to meet the federal poverty level requirement based on where their income is. In addition, that's not the only qualifier. They must fall into one of the other categories, which is their children. They are pregnant women. They are adults and families with dependent children. They're individuals with disability, and they are the elderly. All right, this is a federally funded program that is managed at the state level. It covers inpatient and outpatient hospital services, professional services, nursing homes for persons over 21, pregnancy-related services, family planning, typical labs and x-rays, and coverage at FQHC or federally qualified health centers and rural health clinics. Again, billing should also be done on the standard 837 claim forms. Some people are eligible for Medicaid only after they have incurred medical expenses that reduce their income. So say a spend down. And so if I'm making this number up, guys. If the Medicaid qualifier is 133% of the federal poverty level, and I am currently at 150% of the federal poverty level, I have to spend down in healthcare, and I'm supposed to pay for it, that 17% difference that brings my income down to that 133. Until that is met, Medicaid will apply that against the spend down, and the provider is supposed to actually collect that money from those patients. My statement to you would be good luck on that one. Medicaid is always the last payer to be billed, and all other benefits must be exhausted. Medicaid payments are reduced to the extent that where there are benefits available from any other third-party resource, and sometimes this results in no payment at all being made from Medicaid because the amount Medicaid would have paid as primary would have been less. So there's definitely calculation rules that even if the patient has Medicare as say Medicare or commercial as primary and then Medicaid as a secondary, even if you bill Medicaid for the amount the commercial paid, Medicaid, you may get no reimbursement from Medicaid, and there's nothing you can do about it. There are specific rules on and forms that are needed for things like induced abortions, sterilizations, hysterectomies, etc., that you'll see on the web as well, that you're not going to get paid if those forms were not signed. So there are some requirements with those to get reimbursement. So hopefully you came away with key understandings of particularly Medicare, Medicaid, some of the other commercially funded and managed care plans that you are offering out there in the industry. And we will do a deeper dive of the managed care plans, types, and the requirements. So again, what Medicare is government funded, Medicaid is a federally aided, state-operated program, and TRICARE is your uniform services healthcare program. Okay. So another polling question, keep you guys engaged today. Which option is a federally aided, state-operated program? There you go. All right, well, we'll end up pulling there. I think I made that one really easy for you guys, or everybody's really, really paying attention today. It is Medicaid. Medicaid is for low-income individuals or families that were expanded under the Affordable Care Act in 2014. Benefits were extended to specific individuals under the age of 65, and it is with incomes up to 133% of the federal poverty level. So good job there. So moving on, because we really do have a lot of material to go over here today. We're going to talk about managed care and the requirements for these plans, and again, the burdens that this may place on providers and patients. Types of plans that we'll walk through today. HMOs. I think it's any health insurance plan that provides or ensures comprehensive health maintenance treatment for an enrolled group of persons based on a monthly fee. They'll get to choose a primary care doctor. The doc coordinates the beneficiary's care, and things like referral to specialist or prior authorization will absolutely be in play in those HMO plans. PPO plans is the closest to an indemnity plan. It is a health plan where the employer and the health insurance carrier contract to purchase healthcare services for covered beneficiaries from a selected group of participating providers. Participating providers agree to abide by utilization management and other procedures implemented by the PPO. Some other plans, point of service plans, we've got exclusive provider organizations. They're similar to PPOs in their organization and purpose, but they limit the beneficiaries to participating providers for their healthcare services. So if you're covered by an EPO, you are required to receive all the covered services from providers that participate in that EPO, very similar to an HMO. And if you try to go out of network, you're not going to get covered. Your point of service plans, the primary care docs and the point of service plans usually make referrals to other providers in the same plan, but members can refer themselves outside the plan and still get some coverage, even though out-of-network benefits may not be as, they may have to pay more out of pocket to go out-of-network versus in-network. Medicare Advantage plans, so they're very similar. They've got the Part A, they've got the Part B. They continue to pay their Part B premiums. They may have to pay extra to the Advantage plan for things like prescription drugs. And again, most of them will have some managed care restrictions to try to control those costs. So it's an important key note here. Additional plans that we'll want to talk about, Medicaid HMO plans. are very similar to Medicare plans, right? They try to focus on preventive care, provide enrollees with a medical home for themselves and their dependents. Medicaid managed care plans must ensure that recipients have access to all medically necessary services, but again, use that concept of HMO to coordinate care for utilization management. Capitation, which you may or may not see often in your world, is a method of payment to healthcare providers whereby a fixed amount is paid per enrollee to cover a defined set of services over a specified period of time, regardless of the actual services provided. So regardless of whether I come to see the doctor today, he's going to get a fee. He's going to get paid because I'm capitated to him. And maybe it's $50. If I come in and see him 5 times, he's still only going to get to $50. So there's potential risk there, right, as to cost actually to the provider. So those are important to keep in mind. And then consumer-directed health plan. The subscriber, many of us have those probably today. They agree to a high deductible, typically in $2,000 to $5,000 range, in return for lower premiums. They're typically attached to a health savings plan, which allows the employee to save pre-tax dollars in an account that can be used to pay for the higher deductible. Okay. Which plan pays a fixed amount per enrollee? Give y'all a minute. Yeah, I think I again made that easy for you guys. So you're real smart. Okay, I see that we're stopping pulling, so we'll continue on. It is capitation. I can understand why you would consider that HMO concept to be potentially, but it's a different model than capitation. Again, capitation is clearly just a fixed amount paid per enrollee, regardless of the usage. HMOs are paid and a little differently. They'll get paid for their services as they provide them. Okay, a little nuance there. Okay, so we'll go quickly through the most common contracted payment models. Every payer is going to contract differently with you. Percentage of discounts, I'm going to pay possibly 80% of your total charges. I may pay under a DRG or diagnostic related grouping, which classifies inpatients on the basis of diagnosis for payments to hospital. That's why in coding, getting DRGs with comorbidities to get additional payments very, very important. On an outpatient basis, you may also hear groupers that may be paid more on an outpatient basis, which is very similar. Or actually, that's your APC. It's a system that divides all included outpatient services into almost 600 procedural groups. The services within each group are clinically similar and require comparable resources. So each APC is assigned a relative payment weight based on the average cost of service within the APC. You may get case rates. If the patient is coming in for a hernia operation, we are going to pay you X amount regardless of your cost, because that's the typical cost for a hernia operation in your facility. We've talked about capitation. Again, they're going to pay them a fixed fee per month per member, regardless of usage. And then per diem payments. So possibly you may be negotiating things like inpatient accounts, and I'm going to get paid $500 per day, regardless again of cost or charges for these particular services that we're providing. So there are very clear administrative guidelines with undermanaged care requirements. Contracts that providers sign make it very clear that not meeting these requirements will probably result in non-payment, and the ability to overturn them is extremely difficult because of those contract terms. So providers need to pay real attention and make sure they've got real clarity on managing pre-authorizations, referrals, and notification. So pre-auth is routinely required for elective hospital admissions and outpatient services. So concurrent reviews can be planned and discharge planning can be started. We do outpatient to ensuring it's medically necessary, to monitor and control utilization by evaluating the appropriateness, necessity, and quality of the requested care. So if you think about, I'm probably not going to get a PET scan until I've had the results of an MRI, because a PET scan is going to be much more expensive. Referrals, that's when a primary care physician needs to refer a patient to a specialist, and they need to manage that referral process, probably within that, again, HMO or PPO group or EPO group. Notification is where providers notify the insurance company that insured patient is actually typically admitted unscheduled into an inpatient admission. That's so that case management can provide utilization management services and do that concurrent review while the patient is in-house. Lack of timely notification, whether it's within 24 hours of the next business day, will result in the denial of those initial days that you'll, again, will have to try to appeal why you did not, again, meet the administrative burden. So going in, their concurrent review, typically a utilization review nurse is assigned to the case, and based on the admission, diagnosis, and clinical data, the healthcare plan is going to authorize a length of stay and will not pay for services beyond the approved days unless there is a clinical need to do so. Site of service limitations are where they want to demand authorization or referrals based on where the patient is going to be. So I'll give you an example. I ran a hospital location that had radiology, but we also had freestanding radiology. The way we got reimbursed was we had a higher reimbursement rate in the hospital setting, and we had a fee for schedule lower rate in my freestanding facility. If they went to my freestanding facility, authorizations were not required, referrals were not required. If for some reason they had to come to my outpatient hospital setting, then I needed an authorization to determine and deem why it was medically necessary in that higher cost setting. So that's what they're looking to do. There will be site of service limitations that need to be controlled as well. Key points, I know we went through that pretty quick, but again, we have a lot of information. Each healthcare organization has a compliance program. We need to understand these rules, again, to ensure that patients don't get billed inappropriately and there's not a loss of revenue for the organization. Very administrative, and hospitals are looking to a lot of technology to manage this for them as they move forward. It's not going to get easier, guys. It's probably going to get harder. Okay. Which option is not a specific managed care requirement? I made this one a little harder for you guys. Okay, we got about half that submitted it. So actually, the correct answer is preferred provider organization. Notification, referrals, and discharge planning are all part of managed care requirements. PPO is a form of a managed care plan. It is not a managed care requirement. Okay, good job there. All right, moving on. Keeping an eye on time here. All right, let's talk about price transparency. Due to the CMS mandate effective 1/1/2020, this is certainly a hot topic in the industry right now. So we'll talk about the principles of price transparency, the role of price transparency in patient financial care, and how to get an accurate estimate to a patient. So pricing transparency has evolved based on providers' need to easily provide pricing information to patients. The need is driven by health plan provisions that include significant patient liability portions or consumer driven, such as health savings accounts and health reimbursement arrangements. It can be both provider facing, providing active estimates for scheduled services, and patient facing, allowing patients to shop for services before scheduling to get the best care. And part of this is the need for patients to make informed healthcare choices. Patients are contacting hospitals to proactively inquire about cost and fees prior to agreeing to service. The mandate is requiring that they can't require that anymore, and that shoppable services and machine readable formats are required. If anybody that works for a healthcare provider and knows that the charge master was the initial review of that, I beg you to go out to a provider website, pull down their charge master, and look at it and see if there's anything you can do with it. And I'm going to challenge everybody that I don't think the mandate really does what it needs for patients at all, but it's quite unmeaningful to our patients, to be honest with you. Elements of determining a price. So the first thing I need to know is patient's insurance eligibility and benefits, including their deductible, co-insurance, and co-payments. All right. I think we need to be clear here. Estimates will never be 100% accurate since we don't have real-time adjudication of claims, and those benefits can be changed based on claims that may get processed before yours. Hence, the strong word on estimates, right? The second component of determining a price is to identify the service or the test involved, right? I need to know what the allowed amount is, the CPT codes that we're going to have, and then the health plan information will inform my allowed amount. So hopefully your organization has deployed a technology solution that can help you determine accurate estimates easily for your patients. If not, providers are relying on worksheets or other tools to guide them through determining the information to respond to a price estimate request. To be honest, however, manual processes are time consuming and is more apt to have errors, resulting in inaccurate estimates and unhappy patients. So, you need to know what the contract terms between your organization and the health plan are. For example, are inpatient cases paid by MSDRG, percentage of charges, preset case rate, bundled services, fee schedule, right? I need to know what the contractual rules should be there. We need to obtain the total charges. We need to include all ancillary services, including employed physicians. We need to have exploding charges or paired charges. So like a kidney biopsy, I really hope has an ultrasound. And then we can sometimes obtain ancillary providers like anesthesia, but those are not absolutely the easiest things to do if that's not employed by the physician. So this is, again, just an example. I think there's another one out in the e-learning on how to estimate and calculate. So again, what are my total charges based on my charge master? What's my contractual rate based on how I'm going to be paid? So what's the health plan DRG rate? Where is the patient in their deductible? And then where they are in their out of pocket? And then how much am I going to get from the health plan and how much I'm going to get from the patient? So understanding how you get to that true estimate that you can present to that patient proactively. Okay. So another polling question, guys. What is the first component of a pricing determination? What's the first thing you need to do to inform that patient of what their costs are going to be? Okay, got about half there, so we'll stop it. The answer actually is, and I can understand why this is confusing as well, is the verifications of the patient's insurance eligibility and benefits. I need to know where that patient is in their deductible. I need to know where that patient is in their out of pocket. And I need to know if they even have any actual costs before I provide an estimate. So, or if they have no benefits available at all. So knowing the benefits has to get done first before then I bring in the service or test involved. Because if I'm a patient that I've had extensive insurance bills, I may have absolutely no deductible left, no out of pocket left, no nothing, and it's actually going to cover 100%. Then you bring in the service and the tests that are involved. Okay, hopefully that makes sense when we explain it that way. Okay, all right. Moving on to the next section. Working with uninsured patients is really critical in making sure that we find the right financial path for them. First thing you need to do, again, if they are eligible for Medicaid or your financial assistance program, then there's no out of pocket. There's no reason to present an estimate to them if that patient will have no out of pocket first. So the first thing is to verify if they can get Medicaid or financial assistance. There's no estimate conversation then. Then you get into the total charges. If they're not eligible for Medicaid or financial assistance, apply any self-pay discounts or perhaps a tiered financial assistance adjustment if applicable. Share the results with the patient, explain the discount, and then come to a financial resolution with the patient. But the most appropriate thing is to find out what the patient can pay and get them into a good financial plan for them. I want to focus a little bit about the transparency mandate and what most hospitals are doing. So in 2019, CMS unveiled proposed rules that mandate that consumer-friendly price transparency for hospitals. This is only for hospitals and employed physicians that are part of those hospital services, not doctor services themselves. Like if I'm going to an outpatient physician, that's not a component of it. It's if the employed physician charges are ancillary to a hospital charge. Keep that in mind. So we'll go on and we'll talk about there's two components of it that we're going to spend some time on. And then there are certainly potential fines that hospitals may incur if they're not compliant with the mandate. Healthcare makes it exceedingly hard to get a price, right? You can go out to scheduling services, you can go out to your insurance sites that will probably drive you to their least costly provider. You can go to for-profit sites that might be able to give you some cost, right? But when it comes to price, both physicians, consumers agree that providers are the preferred source of that information. So two primary requirements to publicize standard charges, a comprehensive machine readable file that needs to be downloadable. That includes gross charges, payer-specific charges, discounted cash prices, minimum negotiated charges, maximum negotiated charges. As you can imagine, providers are not happy with that because their negotiated charges are going to be available on the payer website to their competitors. The second component of it is the consumer-friendly shoppable services. I must put in 70 specified and 230 hospital-selected services. 70 are specified by CMS, the others based on usage, to come up with 300 minimum shoppable services, right? We need to provide them with the gross charges and the allowed amount placed upon that contract. The missing piece here that does not help our patients it does not provide them with what their true out-of-pocket is. They still need to calculate that. So I would argue in the industry, we're still not doing enough for our patients within the mandate, and hopefully we'll move forward in some better stuff. So where we think that everyone benefits is patients receive the shoppable price transparency experience they deserve. Front-end staff can provide with confidence accurate estimates. Financial counselors can really know what to have that accurate thing, and actually an organization can provide you with a competitive edge. Okay, so hopefully you came away with the key points of why price transparency is important, both from a patient-facing tool to a provider-facing tool. I'm going to have to speed up here a little bit. What is the first thing you should do when estimating for a self-pay patient? Give it a few seconds. We're going to go through. We'll either go through the next section either quickly, guys, or I'll bring it in, and that's what I may do. See if we have questions on chat. We'll do our next section, which we expected to do. I thought I could get through this in an hour. Verified patient is not eligible for Medicaid or financial assistance is the first thing that you should do, because then there is no patient out of pocket that you really want to have a conversation on. Okay. So what I'm going to do is we are not going to go through the next section. I will add that in. Oh, one more question though. How many shoppable services are mandated by CMS? One more. There's a nuance there. Pay attention. How many are mandated by CMS? And shoppable is also a key concept. Give you a few more seconds. Okay, it's 70. 300 shoppable services are required to be put on the shoppable services component of it. Only 70 of those are mandated by CMS. The remaining 230 should be listed based on your actual usage and volumes. So that's the nuance that I want to make sure we understood there. Okay. All right. Okay. We are going to do this during our next section. So we'll revamp this a little bit, and I'll put this in the beginning of next week's section. And again, if we have to, again, go over this a little bit more, then we'll do that. But take the time to go through it when you go through the other sections as well, when you go into e-learning. So with that, we're going to open it up for questions. We'll start with Anthony. If there are any chat questions that we need to answer, anybody want to join us on video, join us on audio, absolutely, please feel free to do it. I'd love to see your faces. I miss people.
All righty. So feel free to put a couple of questions. We've got a couple of minutes. While the questions are populating, we've already got a few. Just for those of you on this call, a quick shout out for another awesome event we have today. As I'm sure you can see, my patriotic shirt I'm wearing today. We're having at 2 p.m. in conjunction with Florida AHAM Sunshine Chapter, we're having our Decision 2020 Part 1 discussing the platforms. Paul Miller from the National AHAM Legislative Board will be kind of giving us a talk on the two competing platforms from the healthcare lens today. So it is free and open to anyone. So please check out the events page on Florida HFMA and sign up for that. And we'll see you this afternoon. So quick plug. And with that, we'll get into the questions. So Christine, we have a question from Monica. Does the price transparency mandate over the phone, quote, over the phone, shoppable responses as well?
No. No, them having to call and ask for a price estimate is not sufficient to meet the mandate.
All right. Are these slides going to be available?
Yes, we are trying to get these out in advance, guys. We are listening to your questions. Keep in mind, we're volunteers that unfortunately still have full-time jobs. I'm trying to get these done so that we can post them on the website. So go to the Florida HFMA website, and these slides will be available And again, this recording will be available via the YouTube channel. So there's a lot of here. I know I go fast. I'm from New York. If you haven't figured it out, we talk fast. But again, it's to get the key concepts out there for you. Rewatch the video, go out and do your e-learning, and you're all going to pass with flying colors, I'm sure.
Okay, and then a question from Lisa, and how do we access the e-learning? You're going to log in through hfma.org, go to my profile, and then you'll see it on the left drop down, the left link list for my e-learning.
Once you've registered for CRCR first, though, you have to register for it for them to appear in your e-learning.
Right. Angela, timely filing for Medicare is 1 year. Is that from admit or discharge date?
It's going to be from either date of service or discharge date.
Okay, and then another question about the YouTube sessions. We are working on that, folks. We're having a little bit of trouble with last week's session, so keep an eye out, and hopefully by next session, we'll have an update on that YouTube link, and we'll distribute that via the chat. Anything else? Just a quick comment from Rebecca. Maybe we can expand on this quickly with the last couple of seconds we have. It's her understanding that CMS mandates 300 shoppable services, where 70 are selected by CMS and 230 are selected by each hospital. Yeah. Can you expand on that, or just touch on that quickly? Because it seemed to be a bit confusing earlier.
So the 70 are mandated. They have a list published out that tells you if you do these services, you need to put these prices on your website. If you don't do them, you also need to clarify that you don't do them. The remaining, so that 70 has to be at least addressed in that. Whether you do it or not doesn't matter. The other remaining 230 to get you up to the 300 is going to be based on your volume. So running reports based on utilization and looking at your top tests that are performed is then what's going to drive you to that 300. Hopefully that helped.
Any other questions before we close up for today? Nothing yet. Well, thanks everybody. Thank you, Christine. Awesome session as usual.
Yeah, hey, Anthony, don't forget to tell them about the Spooktacular event as well.
Good call.
Yeah.
Good call. While you're there signing up for today's election event, you'll see on the 30th, we're having our Halloween Spooktacular. We have 3 more great education sessions along with a lunchtime Name That Tune DJ hosted competition, a little bit of music trivia where we'll be guessing the artist and the song in a bunch of different fun categories, and Halloween costumes are encouraged. So if there's no more questions, appreciate that, Christine. Yeah, all the events are free, and you know, the Spooktacular, we are taking donations for a food bank in Central Florida. So if you can give, please do. But otherwise, join us. Should be a really good time.
Great. Thank you, guys. Continue with your feedback. We want to hear from you if we can improve this for you. First time doing it, so we're excited and want to make it better for you. Have a good rest of your day, and I'll talk to you hopefully next week.
Thanks, everybody.